The dual antiplatelet therapy, or DAPT study, has really brought a lot more insight into the optimal use of DAPT. And just days before ACC 16, Jack published the 2016 ACC/AHA guidelines focused update on duration of dual antiplatelet therapy in patients with coronary artery disease. So we're here to talk about, in the Jack May 31st issue, a DAPT Score utility for risk prediction in patients with or without previous myocardial infarction. And to do so, I'm with one of the co-authors, Dr. Mauri, who is an MD and a professor of medicine at Harvard Medical School and a cardiologist at Brigham and Women's Hospital. First off, thank you very much, because this is one of the top topics today right now, and it was a lot of the DAPT study that went into the new guidelines from the ACC and the AHA. I guess when we talk about the DAPT score, the first question I would have is, given CHADS and CHADS-VASc and scores like HAS-BLED, why do we need another score?
Yeah, great question. So the DAPT score really came out of the recognition that clinical trials don't tell us everything just by themselves. The single result from a clinical study is difficult for clinicians to interpret. So after we completed the DAPT study, and actually even before, we knew that there was going to be a trade-off between preventing ischemic events and increased bleeding. So the trial overall was positive with a reduction in ischemic events, but had a significant increase in bleeding. So how do you go from there to recommend to your individual patients whether that trade-off is worth it?
So what did you find in this paper?
So in this paper, we used the DAPT score to be able to look at patients with and without myocardial infarction at the time of their stent procedure or in their distant past. And we found that patients who'd had a prior MI had a much higher risk of recurrent events, especially recurrent myocardial infarction, even if they had been stable for the past year. Because remember, the DAPT study randomized patients who'd been doing well for a year to either go on placebo or continue on dual antiplatelet therapy. And those that got randomized had a lower risk. What we also found, though, was that beyond just looking at whether the patient had had a prior MI, if we use the DAPT score, we could more accurately tailor therapy for individual patients.
Now, we have a lot of people who probably qualify for dual antiplatelet therapy, but it's really difficult because there is this yin and yang between the risk of stroke and the risk of bleeding. So the DAPT score is hopefully going to help smooth that out and give us some more information so that we can feel a little bit more confident in the prescription.
That's right. So what's different about the DAPT score from other types of risk predictors is that we actually looked at what were the predictors that would differentiate whether a patient would have benefit versus risk.
Right.
And so you get about a 10-point spread in how the distribution of scores goes. And those patients who had less than 2 versus greater than or equal to 2 had different benefits and risks. So those with a low score had really very little benefit, but had a lot of the harms associated, the increased bleeding, whereas those with greater than or equal to 2 had a tremendous benefit in terms of reduction of myocardial infarction and stent thrombosis, and a minimal difference in bleeding, and no impact on mortality either direction. So it's very helpful because in clinical practice we know that there are patients with prior heart attacks or patients who've recently presented with a heart attack who have high risks of bleeding. And in those patients, we really don't want to continue therapy. And in patients who have stable angina, we might be wondering whether some of our patients might still actually be at high risk for later events. And so the DAPT score gives us a more quantitative way to assess that. It's difficult for us to do that as individual practitioners because there's so many different factors that go into it.
And you were actually looking at different time points too, as far as whether the MI was quite a ways back or more recent. And the risk was pretty much the same if there was an old MI as opposed to a current one.
That's right. It's interesting that, remember, all of these patients had been stable for at least a year.
Right.
But those patients who'd had a stent a year ago, or those patients who'd had an MI even multiple years prior to their current stent procedure, they had very similar risks over the long run. And so that was a new finding. We didn't know that would be the case necessarily.
And I guess the last thing is, what goes into the DAPT score, and is it easy to calculate?
Yeah, so there are about 9 factors that go into the DAPT score. Age is the main one for bleeding, but there are multiple predictors for ischemia. And they generally are clinical factors such as whether the patient's had a previous MI, or a recent MI with a stent procedure. Also procedural factors having to do with the extent of disease and the extent of the lesion that needed to be treated, diabetes, smoking. These are the sorts of things that go into it. It's easy to calculate because there's a way to access it online. There's a daptstudy.org web calculator that can be used, so you don't have to memorize it.
So the clinical application right now, what would you say?
I think it's helpful for that patient who's sitting with you a year after their stent's been placed. They've been doing well without having had any bleeding or any reason that they need to absolutely go back on antiplatelet therapy, for you to help make that decision. The low DAPT score patients, I would tend to say those patients would probably do better without continuing, whereas those with a higher score, we should think about continuing, that they might have a greater benefit.
Well, this paper is in the May 31st issue of JACC, so please look for the paper and its accompanying editorial commentary. And for Cardio Source World News, I'm Executive Editor Rick McGuire.